Welcome to the next BrainBook Academy video. Previously, I went through some of the things that you need to start doing to gear up your CV for a career in neurosurgery. In the comments, a lot of you wanted to know more about what clinical audit is and how you can do one, so here's a primer. I'll start by going through all the individual components, and then at the end there's going to be a step-by-step guide of how you can do a clinical audit in practice. One of our first clinical audits ever undertaken was by Florence Nightingale during the Crimean War of the mid-19th century. Nightingale arrived in a barracks hospital in a town called Scutari in 1854 and was absolutely appalled by the unsanitary conditions and high mortality rates amongst injured soldiers. Knowing what her own standards of care were and the conditions that she would expect at home, she introduced new sanitary routines and really cleaned up the barracks hospital. Importantly, she documented what the mortality rates were before her intervention and then what they were afterwards. Following the changes that she made, the mortality rates fell from 40% to 2%. The results were absolutely instrumental in overcoming British doctors' and officers' resistance to the procedures that she wanted to institute. Her methodical approach, as well as her emphasis on uniformity and comparability of those results, is recognised as one of the earliest programs of outcomes management and clinical audit in medical history. So what exactly is a clinical audit? Clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review against explicit criteria and the implementation of change. That means that we're improving the quality of patient care by taking a look at what we're currently doing and then modifying it where necessary. For those of you going for core surgery or neurosurgery national selection interviews, it's important to choose one relatively simple definition and stick to it. Your interviewers will thank you for it. So maybe something a little bit like this. Clinical audit allows us to improve our standards of clinical practice. Aspects of patient care are evaluated against expected standards of care, and where necessary, changes are made at an individual, team, or service level. A re-audit can then be used to confirm that improvements have been effective. One of the first questions that people commonly ask is this research? Or what's the difference between clinical audit and research? There is an important distinction, and it's often confused by clinical teams. Firstly, clinical audit is based on facts or standards that have already been established, whereas research asks the question, what should best practice actually look like? Secondly, clinical audit is specific to one setting, whether that's your group of patients, your ward, or your service. Research can be replicated, and the results of this can be extrapolated to general populations on the whole. And most simply, clinical audit is rooted in practice, whereas research is usually initiated by researchers. Broadly speaking, you can ask these two questions and they'll help you decide whether your work is research or clinical audit. Firstly, do I want to measure current practice against evidence-based clinical standards? If so, then you're probably going to be doing a clinical audit. The second question is, do you want to investigate the effect of a new treatment on patients, for example? If yes, then that's research. Now, let's say you want to do your clinical audit. The first thing you've got to do after you've chosen a general topic is to create some aims. When we're trying to define the aims of our clinical audit, this should be a relatively broad question or statement of intent. The aim could be something simple like to improve the care that patients with lumbar drains receive. Don't worry about the broadness of this because you will be going into more detail later. Next, you need to set clear objectives for your clinical audit. For a clinical audit to be successful, it needs to stay focused. And you've got to decide why the audit needs to be done and what you're hoping to achieve from it. That's the point of the objective. In reality, what this means is that you've got to write some written statements that describe really clearly what is going to be measured and to provide a way in which the success of your audit can be measured. You can definitely have more than one objective. And when you're trying to write your objectives, you can use words like assess, determine, ensure, and they're very common words that are used. Again, another neurosurgical example, and this is hypothetical, is that to ensure that all patients who undergo a lumbar drain procedure receive appropriate DVT prophylaxis. That's an objective. Now, you've written this objective, but you still can't measure anything with this. What does appropriate DVT prophylaxis mean? How many of these lumbar drain patients are supposed to get it? This is where your audit standards will come in. The standards will define exactly how these aspects of care are going to be measured. So, on to the next step. Let's set the standards. And this is really key because this is the whole point of clinical audit, comparing the actual practice with evidence-based standards of good practice. Once you've chosen your aims and objectives, we're going to figure out exactly what kinds of standards you need to be setting. Now, you can get your standards from anywhere. These could be key recommendations from NICE, they could be from the literature from peer-reviewed journals, they can be from international guidelines or expert opinions from the Royal Colleges. If you can't find any evidence-based standards, you can go to a group of consultants at a local level and get a consensus of what is expected of a standard. But that is a slightly weaker position to be auditing against. Now, you need to write up those standards in the following format, and it tends to look like a table. On the left, you're going to have the audit criteria or the standard. Then you're going to have the target percentage. Then you're going to have the exceptions, and then you're going to write the source of your evidence on the far right. When writing your audit standards, it is normal to set your target at 100%. This is the standard level of care or the standard thing that you will always do for every patient. You're essentially saying that if this is supposed to be the best practice, then all of my patients should receive it. However, as with anything in life, there are usually exceptions to the rule for not providing this level of care to 100%. And you need to sit down and identify these with a senior that's helping you through this audit. A good example, and again this is hypothetical, you might say that all post-operative patients should receive prophylactic anticoagulation to prevent DVTs. A really obvious exception to this might be if your post-operative patient still has a bit of active bleeding. So that's a really obvious exception. Now, moving on, we're going to start collecting the data. And this is once you've got these basics down. Before you start collecting your data, you need to figure out exactly what you want to collect from the medical records. And this is really important so that you don't collect reams and reams of really useless data and waste a lot of your time. Make sure you design a data collection pro forma with the team that's helping you or with your seniors. It doesn't matter if this is a handwritten piece of paper that just has demographics and all the key data written on it, or if it's an Excel spreadsheet. Excel obviously has the benefit of allowing easier data analysis, and it lets you export graphs and so on and so forth. You also need to decide whether you're going to collect your data prospectively, and that's moving forward, or whether you're going to go backwards and start collecting this data as a retrospective snapshot in time. They both have their own pros and cons. The obvious main con of a retrospective audit is that often medical records can be incomplete, which can be a really major nuisance. Now, another common question is, how do you figure out your sample size? How many case notes do I need to pull for the problem? Or how many patients do I need to go through to make sure I've got enough? Remember, first and foremost, your audit is not a piece of research. You're not bound by the same rules as research. So you don't need huge sample sizes to power your study, because this isn't a study. You can usually get the information that you need from smaller sample sizes, and clinical teams often use some kind of rapid cycle sampling of lots of small samples to really get a quick answer to their question. Again, you're going to need to look at the specifics of the question that you're looking at and the amount of information being collected, how easy it's going to be to obtain all of that information, and what resources you've got available to help you. So before we move on to what we need to do as part of the audit process, this is what an audit cycle looks like in general. As you can see, it's a cycle with lots of steps, and you go round and round until you have raised the standard of care within your unit. And that's when you have closed the loop or closed the cycle. And that's when your audit is truly complete. Not after the first audit cycle and before you've implemented a change, but once you've implemented a change, gone through the cycle again, and you no longer have any changes to make, or you've reached that bar. So now, putting it all together step by step and going through some of the smaller logistics, this is your guide to doing the clinical audit. Step 1. First, choose your topic, preferably one that's high priority for your ward or team. This could be anything from infection rates and certain procedures to the amount of time that patients are kept on an emergency surgery list, for example. Discuss it with your team or a senior who's going to be supporting you through the project. Step 2. This is really important. Do not skip this step. Find your local audit office. Pretty much all hospitals have got them, and they will let you register your audit with them. At the same time, they'll also provide you with a template, sometimes a proforma data collection template, and definitely the form that you're going to need to fill out afterwards to report back to them. They can also tell you if your audit has been done before. Step 3. Choose your standard of care that you're going to compare current practice to. Step 4. Select the criteria that are going to help you compare your practice. This could be something as simple as all patients who are smokers should be offered smoking cessation advice, and then define what the optimal standard for that is, the exceptions, and the target percentage. Is it 100% of those patients, or would you be satisfied if 80% hit that target? Step 5, go out, collect that data. In some hospitals, that's going to mean grabbing physical notes for a certain number of patients, or in some hospitals, that'll be electronic patient records. Again, having been through both processes, they've both got their pros and their cons. Step 6, analyze your data, compare what you found to your standard. Importantly, you need to start thinking at this point about why the standard is not being met and what you can do to make it better. Once you've done that, you can move on to step 7, which is presenting your findings at a local meeting. It's a good idea to discuss your findings with seniors before the meetings, just in case you found some horrendous result that nobody knew was happening. And it's good that people aren't caught unawares or unexpected, because that can cause a bit of drama sometimes. At this meeting, and once you've presented it locally, there will be a plan of action that will be made. Certain team members will be made accountable for ensuring that the plan is in place, and a specific time frame will be given to enact that plan. Your local audit office will also want an audit report that they can store and refer to, and again, they will provide you a template for this. Finally, step 8, repeat your audit after a specific time interval. And this is the whole point of the cycle. You keep repeating the process and implementing changes until the service reaches the standard that you have set. At that point, you've completed an audit cycle and you have closed the loop. So congratulations. Now remember, these audits are super important to do. They're a really nice, easy way of really raising the bar of patient care in clinical settings. And if you're going for national selection or for core surgical interviews, audits are a really, really key part of the interview process. Do not leave this stuff till the last moment, because a lot of the times, after you've done the first cycle of your audit, you're going to want to leave about 3 to 6 months before you re-audit what you've implemented. You can't do that a month before your interviews. If you've got any comments or questions, drop them down below and I'll try my best to answer them. And don't forget to subscribe if you want more of this. See you next time.